ready?
Yes.
So let me welcome you to our 5-day webinar series. We have done about 315 so far. We have had the privilege of 6 Nobel laureates come to us, and they have come and spoken on various topics. Of course, topics in which they have got their Nobel Prizes. And we have also participated in the G20 presidency that India was holding. We did 11 under the new international economic order. Little did we know that the new international economic order will usher in very fast and very rapidly and very different from what we anticipated. And we did 6 on women empowerment, and we did another 6 on climate. And in the last 1 year, we have done 6 on Trump tariffs and how are we going to be impacted. I'm in a small town in India called Dehradun. It is towards north of Delhi, and they are all planning and discussing about how to make it Viksit, because if we want to have developed India, we need developed states. That's the focus of today's and tomorrow's conference. And I'm surprised, even in a small town like this, the focus of discussion is how the disruption in trade is going to impact the economy of the country and that of a small town like Dehradun. So well integrated is the world. So I think when we did 6 webinars on Trump tariffs, little did we realize that each one across the globe is going to be impacted by what is happening there. And I'm sure what has happened in Davos in the last 2-3 days are known to everybody across the planet. That's the impact that's happening in the international economic order. So we have covered those topics, and we generally focus on contemporary economic issues and burning issues that are really important for the country. Today's research is again an important issue, very important issue, which we have invited Professor Jesse Anttila-Hughes, who's an associate professor and the current chair of economics at the University of San Francisco. He has done his undergraduate studies at Harvard, and he has done his PhD in Columbia University in sustainable development. I was just mentioning to him, so jealous because I couldn't do it at Columbia, and he's done it at Columbia. So jealous of it. Great place to be in. And later on, when I was working at the IMF, I saw people from Columbia. They're fabulous. The training at Columbia is fabulous.
Thank you.
His research combines physical and statistical approaches to economic health and social problems, illuminating the dynamics of coupled human environmental systems ranging from climate change to planetary public health. His research has been published in leading journals across the world, and his work has appeared in news outlets such as Physics Today, the Wall Street Journal, and the New York Times. He just told me he's from New York himself. He has been the 2015 recipient of USF's Mentor of the Year Award in recognition of his work advising graduate students, as well as the 2023 USF Innovation in Teaching with Technology Award for his work on introducing students to AI and LLM methods in econometrics. He has served as a research advisor for institutions such as the World Bank, DFID, and World Food Programme, and previously worked in the private sector as an investment banker. To chair this session today, we have our founder director and my dear friend and colleague, Dr. Rattan Chand. Dr. Rattan Chand has worked for many years in the government, and then in the last few years, he has worked in Niti Aayog as a consultant and the World Bank as a consultant. He has immense experience in issues related to statistics, as well as female labor force. With this, I hand over the session to Dr. Rattan to carry the proceedings further. Rattan.
Okay, so good afternoon, and let me welcome Professor Hughes, first of all, and all other participants. The topic of today's discussion is mortality from marketing of infant formula in low and middle income countries. I think we are going to have a very nice and excellent presentation. And let us listen to Professor Hughes. So I hand over to Professor. Thank you very much, kindly.
There we go. Thank you very much. Okay, so my apologies, and I'll just have to say advanced slide each time, which is annoying, and my apologies for having to set it up that way, but here we are. So to cut things short, what I was going to say before I hopped into the slides is that this is an unusual time in the global economy. I, in particular, would just feel compelled as an American to apologize to my colleagues elsewhere about what's going on in the States. And if there's a single thing that I think those outside the United States can do to help influence American policy these days, you know, this is a crowd of economists and technical specialists. And I think that telling your American colleagues what you think about what's currently going on in the US government is actually very valuable. And what I was going to give you guys a link to is if you just go to my website, Anttila-Hughes.org, you can find my contact info. One of the big changes that's happened in the United States in the last year, where I think English-speaking technical professionals, in particular people from India, can make a big difference, is on the new version of Twitter called Blue Sky. Blue Sky is where all of the journalists are. It's where a whole bunch of the scientists and professors are, a bunch of the economists. And so I'd say, especially if you are an Indian economist in this domain of policy and technical stuff, and you want to engage with your American colleagues a bit more on social media, Blue Sky is excellent. Come find me there. In any event, for the paper at hand, today I'm going to be presenting mortality from the marketing of Nestle infant formula in low and middle income countries. This is work that is joint with Leah Fernald and Paul Gertler, who are both senior faculty. Paul's quite famous in development for a lot of his work in implementation in RCTs. And then this is also with Bruce Wydick at University of San Francisco and some of our graduate students, Patrick Krause from San Francisco and Eleanor Tsai from Berkeley. Next slide, please. So I'm going to give you an introduction, some background on the Nestle controversy, which I think I'll probably move through a little quickly, given that I had some technical difficulties there. And then onwards we'll go. Next slide, please. And for each of these, you can just, for any of the text, just go all the way to the bottom so that I don't have to. Thank you very much. Exactly. So the Nestle infant formula scandal is famous. That's part of why we worked on it, right? In particular, I'd say if you are a development economist of a certain vintage, Nestle was one of the classic major cases in public health from the first, post-colonial wave of emerging consciousness. The general scandal was that Nestle was introducing baby formula into contexts where the technology and the culture and a variety of other factors conspired to make it much more dangerous than in developed countries, causing increased infant mortality. The scandal itself was the reaction to this. In the 70s and 80s, particularly in the late 70s, we got a lot of this outflow of, what we can think of as very modern development humanitarian type literature, some of the first big corporate gotcha type work that we've seen in modern international business. This led to a large number of boycotts, a lot of activism, and the actual framework that is currently still in place for international baby formula regulation. It also kicked off what's this fundamentally very interesting cultural story about how do we approach optimal social responses for necessarily messy processes like breastfeeding, right? And so we now generically take a breast is best approach. This is markedly different from a century ago. And so, this is one of these big corporate scandals that we get taught a lot in business schools for instances of corporate social responsibility. The thing is, and the motivation of the paper was, the actual evidence on this was pretty scant. in the sense that a lot of the early work that was done on Nestle was done in the 70s, where we had firsthand journalistic accounts of children being exposed to dirty water and dying and similar, but we didn't really have anything in the way of population health estimates. And so what we're trying to do in this paper is basically a big historical economics paper to look back at this major event and see if we can come up with something that's a little bit harder in terms of numbers. Next slide, please. What's interesting is that, this is a project, I will confess, that's been going on for about a decade. It's a big historical project, a lot of pulling data from old 10Ks, the annual reports that we use in the American financial system for public reporting from firms. Many instances of the paper being done. What we find interesting, actually, one page fire, if you don't mind. Go back one page if you don't mind, sir. One more behind. There we go. A lot of motivation. Next one after this. Yes, there we go. And so what we're trying to do here is now basically estimate the effects of exposure. Oh, that's what happened. Okay. Estimate the effects of exposure specifically by using mortality records. And what's nice about the mortality records is that a lot of the work that I do in climate change uses mortality and morbidity records because they are very hard to fake. And so, infant mortality records are one of the few domains in which we can get really good backwards looking data on public health. And that was basically the setup for this paper, because once we realized that we could combine that with prior corporate filings, then we realized we had a nice natural experiment. In particular, what we're able to do here is, at least to our best ability, try and deconvolve this into two effects. One is our colleagues in public health will tell us that one of the principal benefits of breastfeeding is that it passes a variety of antibodies, a variety of complex micronutrients. It helps the mother inform the child's metabolism and autoimmune system about the local environment. And so there are a lot of health benefits to breast milk per se. And so part of what we're worried about here is the potential health effects of simply getting rid of breast milk and replacing it with formula. The second major issue, and this is again something that the anthropologists really warned us about, is that introducing and using baby formula requires an understanding of water sanitation practices. And in many cultures, children aren't given raw water until they're old enough that their stomachs can deal with it. But introducing baby formula means that water sources that might not normally be infant safe, that could cause potentially fatal diarrhea, suddenly get introduced. And so that is what we believe to be the general sort of category of the effect here. And to a certain extent, this paper is a big sanitation paper. I said, gone through multiple versions of this paper. In particular, somewhat funny thing that happened to us is the large set of changes in the differences literature, in particular related to two-way weighting and bias related from estimating things in a panel, meant that we have now completely redone a variety of aspects of the paper with the modern estimators and are currently in last stages of submitting it to actual journals. In terms of how to think about the contribution here, I'd say there's kind of three major areas. The first is what we often hear called forensic economics, in the sense that this is a major corporate financial responsibility event, social responsibility event, and it's telling us in particular about the damages that were caused by potentially nefarious activity. We see a lot of this sort of econometrics applied to firms, individuals, and similar, trying to come up with evidence for a crime ex post. And so to a certain extent, this is a big historical forensic econ paper. Obviously, it speaks to the literature on breastfeeding and child health, which is, to be frank, a minefield. All kinds of interesting normative problems with pushing towards breastfeeding and pulling away from it. It is a politically fraught topic with good reason. And lastly, we're also speaking to the literature on broader corporate social responsibility. Next slide, please. And so generically, breastfeeding is one of these problems that's dogged us for a long time. We cannot all produce milk, right? Not all moms can produce as much milk as their children need. Not all moms have the ability to be around the baby as much as they need. And so we've canonically had, women who worked as wet nurses. We would substitute with animal milks, etc. And there's various problems in this domain. Next slide, please. In particular, with industrialization, you could no longer do something like go over to your local farm animal and get fresh milk that way. And so the same set of processes that resulted in, for example, the British losing a lot of their native cuisine and putting it all in cans of mushy peas led to things like the production of commercial breast milk. Right. So we had the first modern commercial breast milks in the late 1800s, produced by the German pharmaco complexes. Next slide, please. And fill this one. Thank you. And like with a lot of the other industrialized modern products, all these various technologies, then spreads quite rapidly. What is interesting about baby formula, I think from a development point of view, is that this is one of these inverted U-shaped development trajectories, in the sense that baby formula starts getting adopted in poorer contexts as they first develop, right? But we see in all these different contexts, the US and Europe, it's similar, that there's this peak in formula feeding and a return to breastfeeding over time, right? So by end of the late 50s, Americans post World War II are at peak formula consumption. But then as female labor supply starts to come online, as incomes go up, as all of the complex politics of breastfeeding starts to kick in, US European mothers actually start to turn away from formula in the 60s. So this would be the other side of the inverted U. Right. To a certain extent, breastfeeding is a luxury good. And as incomes have gone up, many families in lots of contexts, much like people will opt to have a mom not work outside of the house because it's a luxury, but a valuable one. People will opt to engage in breastfeeding even though it is time-wise and similarly costly. What this means, though, is that there's this fascinating development story that's embedded here about the firm itself then responding to these development processes, turning away from the American and European markets and toward the developing world. Next slide, please. Thank you. When we look at the developing world post-World War II, we see drops in breastfeeding that are even more extreme than what happened in the earlier stages of development in the global north. Right? We see places like Chile where breastfeeding declines from 90% to 10% in a decade. Right? Or Jamaica, where 90% of mothers are bottle feeding children before 6 months. And then in context after context, Mexico, Nigeria, right? Urban China, even though it's completely separated from the larger set of international and global production networks, Singapore, Taiwan. And so this is all happening at a time when a bunch of modern global public health and medicine is actually settling on the idea that breastfeeding is the best approach to infant nutrition. And so we have this sort of, the corporation is moving one way against the tides of what everybody else is saying is best practices, obviously because it's profit maximizing. Next slide, please. And so here we have, nice little graphical representation. We see Chile, the extreme drop on the far left. Singapore, also very, very extreme drop, although in twice as much time. And so our paper is in essence saying, what did this massive drop in breastfeeding that came from the introduction of formula lead to? Next slide, please. And so, in context after context, this stuff was developed. There's many ways of thinking about these processes. It is a fascinating product. I think in particular in the Indian context, with all of the cultural weight that milk and dairy has, I think it's a particularly fascinating thing. You could do a whole PhD just thinking about what was going on in different countries, thinking about formula compounds and similar. One of the classic things, for example, is that these formulas were often supplemented with sweeteners, which also potentially has huge issues. My co-author, Paul Gertler, has done a lot of work in the past couple of years looking at the impact of introducing sugar early into children's diets and showing these potentially very bad long-term metabolic effects, the sorts of things we see in diabetes and similar. Especially earlier on, these were not necessarily the best products. And so, as things have moved forward, Nido, for example, looks quite different than it used to. Next slide, please. There's this huge controversy that first starts to kick up really in the early 70s. And there's this pamphlet, The Baby Killer from 1974, which is probably the most common, famous one. Next slide, please. It is, a very classically 70s text, really sort of over the top, really feels like it's one of these things that came out of San Francisco, where I am, in terms of being a set of relatively, black and white, accusations of the man. But in this case, it was very much the sort of thing where that was the problem. We had what seems to be in particular a lot of early practices. Next slide, please, if you don't mind. Where we had the introduction of, what were called milk nurses, right? There's a lot of pushing of the formula onto moms in contexts where they would get, some exposure to the milk. They would then potentially try to stretch the milk out, add some more water to it. A classic problem with the formula provision, one of the things that was marked as particularly insidious, is that if a breastfeeding mother doesn't breastfeed for more than a couple of weeks, she's at risk of stopping producing milk. And once milk production stops, it can't be restarted. And so one of the principal accusations that was levied against Nestle and a bunch of these other firms, Nestle was the largest, is that they would give enough formula such that if a mom just continuously used the formula, she would lose the production of milk, so she would be hooked on buying formula. So, you go through a variety of these domains. A key thing that pops out is that on top of everything else, the understanding of sterilization and the risk of germs and sanitation, is a modern thing, right? All societies and civilizations have to go through some form of period of densifying and dealing with modern sanitation problems. And this is flagged very early on as the obvious risk with formula. Next slide, please. What makes this a funny corporate social responsibility paper is that Nestle has fought the allegations in various ways over time. Let's just say that they have contacted us about this paper even. And so, they first filed a lawsuit against the gentleman who had written up the Baby Killer pamphlet. They then get a bunch of negative publicity from that. Next slide, please. And so one of the things that's quite interesting about this is we already have, to a certain extent, a major controversy peak for this in the past, right? We had people at UCLA saying that there were maybe 10 million infant deaths per year that were attributable to this, that there's this really large-scale welfare burden. And this is from, again, like I said, for development economists of a certain vintage, this was a classic story, right? This is the kind of thing that you keep in mind the way that we would think about maybe Monsanto or something like that today. Next slide, please. One thing that I will note, right, is that 10 million from UCLA was a little bit high. Most people at this point were doing back of the envelope estimates of how many children they thought were being murdered here. How many children they thought were being exposed to negative sanitation and dying here. They estimated approximately 1 million globally. That turns out to be pretty close to the estimate that we get, so we just like to flag it. So USAID, UNICEF are both saying that maybe 1 million children per year were dying because of bad sanitation exposure. Next slide, please. The fact that sanitation is a serious killer, right? It's not uncommon to see mortality effects from sanitation on the order of, 100 to 200 deaths per thousand in terms of marginal risk. You introduce a child to a bad disease, the child's likelihood of getting diarrhea and dying is very high. And so, we're not able to speak too much to what general mortality rates looked like back in the 70s, although we have some data on it. But they were certainly high enough that they spurred action even then, right? There was a large boycott. Finally, in 1984, we got the onset of Nestle agreeing to radically change its processes for marketing formula. Right? So 1984 is sort of this supposed to be a turning point year. Next slide, please. In 1984, we then get sort of this bit of momentum that leads to what is now the current international governance and regulatory framework for baby formula marketing. The International Baby Food Action Network basically is able to pull together a set of rules that are supposed to be followed, and documents that Nestle continues to not follow the rules. The boycott spreads. Next slide, please. And so, even today, we still get a variety of behavior from these firms. One of the funny stories that we have about this paper is about 8 years ago. We had a graduate student who was working with me on another project, and she was from Nigeria. And we were talking about the Nestle paper, and she stops and she says, "Professor, back in Nigeria, I worked for Nestle in one of these jobs. I was a milk nurse. Like, I was in college, and it was one of the jobs you could get. And they gave you an outfit so that you look like a nurse. And they took us to the back of the hospital because you weren't supposed to see us go in. And we would go into the new moms, and we would be like, 'Hi, would you like some formula?'" And this was, in Nigeria in the early 2010s. And so, this is an ongoing problem. Exactly, we cannot and should not get rid of baby formula, in the sense that there are many moms who need to be able to have an outside option besides breastfeeding. And, the gendered rights and aspects, part of this is quite important. This is part of why, in writing up this paper, one really has to be very delicate with the normative injunctions, right? It's not that women should do this or women should do this. This is a complex set of processes, and we're economists here. It's not like we're saying that Nestle shouldn't exist or that they shouldn't produce formula, but what is best practice? Next slide, please. So key for us is that Nestle has been the largest supplier of formula this entire time, right? We still get estimates that mortality is occurring. We're just not sure of what. And so this motivates our paper. Next slide, please. In the paper, we've got two main sources of data. One is from demographic and health surveys from USAID, which, as of last time I checked, still at least somewhat exists. Again, my apologies from the United States of America for what's going on. We'll see what we can do. Demographic and health survey data are fantastic. I've used them many times for a whole bunch of different work in climate. In particular, the key thing that we get here, the thing that really, really makes it extraordinary, is the demographic and health survey data have retrospective fertility and mortality data for every mom that they interview. So for millions and millions of women around the world, we have their full record of child fertility and any possible infant mortality backdated. So that allows us, even though demographic and health surveys don't start until the late 80s, it lets us look all the way back into the 70s in terms of historical recall, which turns out to be very important for building the sample of what we're looking at. The other source of data that we have here is Nestle's public annual reports that it files as a corporation. And these allows us to basically see exactly when it was that Nestle began importing. Next slide, please. So this was, as mentioned, I'm a former investment banker. This is a nice example of skill complementarities in action. When my colleague Bruce Wydick and I were talking about this paper, he said, "Gosh, Jesse, it would be so cool if we could use the demographic and health survey data to take a look at these Nestle things." And I was like, "Well, Nestle is a Swiss firm, and the Swiss really like to write things down. So we should just go check their annual reports and see what they have." And notably, in the Nestle annual reports from 1965 to the present at least, there is a category for whether or not they import or produce baby formula. So this is a nice example of us saying, hey, wait, part A and part B can just go together and give us exactly what we want. We can look back in history at what specific year a country started to import Nestle baby formula. Nestle was the largest firm at the time and typically the first actor firm, right? Much like Coca-Cola went out everywhere else before all the other sodas. Nestle baby formula went out across all kinds of different countries way before a whole bunch of other consumer products. So we can reasonably here believe that we have got a nice, straightforward difference type design. Next question, please. I'm sorry, next slide, please. In terms of descriptive statistics, we've got a pretty broad selection, mostly from Africa and Asia. We've got Dominican Republic and North America. That's largely reflective of the demographic health surveys sampling. Next slide, please. The one sort of important thing to think about this is how endogenous was entry, right? To what extent can we treat this difference in difference assignment of Nestle as if it were exogenous? And so we've done some work both in terms of what Nestle said at the time and in terms of what we can show, for example, here in a simple model looking at the probability of entry. Nestle was basically a profit maximizing firm. They were looking for the largest markets with the richest people. And so larger countries with higher incomes were more likely to have Nestle entry, but not necessarily countries that are growing faster, not ones that had some kind of ease of business score that was higher or lower. Even birth rates per se, once you control for population size and per capita income, have no real effect. So to a certain extent, we're saying that this is related to the background development process, but it's not even related to the growth rate per se. So we're saying it's plausibly exogenous enough for the behavior of a firm in the past couple of decades. Next slide, please. So our control countries, we pick from the DHS data to try to get a reasonable amount of balance here. I won't go into too much detail to say that the controls match pretty well. B, that generically these results stand up regardless of which controls we use. The one major question, and part of why this paper has been sitting in review for a couple of years, is that throughout this entire period, thankfully, mortality rates are coming down pretty quickly in all these countries. And so there's a background set of questions about how we think about modeling trends here. So we know very firmly that Nestle entrance results in this big increase in mortality amongst households with poor sanitation. But we're not sure, depending on controls, about like the main trend line for overall population. So that's one of these areas where we've taken a bunch of different approaches to kind of smooth it out. We're trying to make all of our referees as happy as possible. But yeah, basically the controls don't change the result too much. Next slide, please. In terms of the estimator, I won't get into too much detail here. This is the simple difference in difference estimator that we use for a two-way panel. In particular, we're using the Borshak estimator. In general, this is good old difference in differences. So we're just trying to think of treatment versus control being exposed to Nestle versus not over time in a panel. Next slide, please. Generically, we're going to be looking at the 3 years before and 5 years after entrance, which is going to be giving us our event study graphs. Next slide, please. And let's actually do one more beyond this. My apologies, that one shouldn't be in there. Thank you. There we go. And it's, again, small, but this is the problems with not being able to share one's own screen. Here we see our main result. Right, and so what we see is in the first two columns, the average effect of Nestle entering into your country. And what we're doing here in particular is we're partitioning the sample into two halves, right? The first is households that have clean water. The second is households that don't. Now, the DHS data gives us data at time of survey on sanitation. So generically, the way that we're thinking about this assumption is that households that currently do not have clean water can presumably not have had clean water in the past. There will be some households that have clean water at time of survey that did not have clean water in the past, obviously, but generically, we're hoping with this process, much like household electricity, household sanitation, a variety of these infrastructural type things, once you get the infrastructure, nothing really changes. In essence, what we're showing here is in terms of deaths per thousand, insignificant 3 deaths per thousand for normal households, but 19.35 deaths per thousand in unclean water supplied households, right? So this is basically what is the mortality rate for children born in the 5 years after Nestle entry for a household that has an unimproved water source. It goes up by about 2 per 100 births, right? 20 deaths per 1,000 births. Columns 3 and 4 then show this estimated as event study. Let's actually just go on to the next slide. and we can just see these things plotted out, right? So on the left, we can see, again, like I said, depending on which controls we use, sometimes the signal in normal households actually becomes positive as well. This is the kind of thing we really want to be careful about, because the sanitation story is obvious and clear and pops out of the data very strongly. As you can see on your right, we get this big increase in mortality that happens in the unimproved, unclean water sample, right? So to a certain extent, we can think of this as being, capturing the divergent point, right? Nestle enters at that dotted line. If you have clean water in your household, we don't really see any action in infant mortality. If you are a dirty water household, you are now introducing the pathogens as a vector, and the child dies, or at least increases the probability of dying. Next slide, please. We do a variety of ways of checking this. What's wonderful about the DHS is it's extreme microdata, so we can actually use mother-level fixed effects on this and look at changes in mortality between kids. That still shows up as a 13 per thousand increase in mortality, so that's any possible things that might be going on in the background related to the mom's identity. We're absorbing with those fixed effects. Also holds up with administrative unit and country fixed effects. And like I said, the point about the controls kind of pushing around our baseline trajectory, in the very last column over here, we could do country, birth year, mother fixed effects and look at the Nestle entry differential. And we're still picking up a 10 per 1,000 increase in mortality in what's basically the most exacting specification we can, controlling for all aspects of the mother, all aspects of that specific period in that specific country, and just looking at the Nestle differential between mothers' births. So, next slide, please. In the story of this whole thing, recall that Nestle in 1984 agreed to adopt a new set of standards after the first wave of problems with the infant mortality data. With the infant mortality accusations. And so what we see here is that 1980, limiting the sample to post 1984 does not change the effect. It doesn't seem that Nestle did anything material to change that. We also, the DHS data do involve recall data on births. So we limit to only births that happened in the last 15 years, which you might plausibly think are better remembered. Still get the same effect. Next slide, please. We are able, so part of the problem with the DHS is the breast milk data, the breastfeeding data is only contemporaneous. So it's not actually something we can use for our work. We go back and took a look at data from UNICEF infant feeding and see whether Nestle presence is associated with any particular changes in behavior. So this is just raw association. What we do find is that, just having Nestle in your country increases the baseline likelihood that the baseline rate of formula feeding by about a third. It is by about a half, right? And it has a large increase in the probability of very young children being given no breast milk whatsoever. So, again, this is one of these things where we're trying to kind of check to make sure that our, results here are lining up in terms of magnitudes. And yeah, it's Nestle on its own is a large enough firm that we can pick it up even in the raw formula cross-section. Next slide, please. And so we do a couple of back of the envelope estimates here. Is this 20 per thousand plausible, right? So first thing that I say, is that this is a large effect. Mortality rate for infants in Europe is like 3 to 4. In the United States, it's like 5 to 6. In India, 10 years ago, it was like 40. Now it's like 25 because India's been doing such extraordinary stuff in sanitation, right? And so this is, it's a reasonably large effect, but not ridiculous in a couple of different ways, right? We in particular do some back of the envelope, trying to get, estimates of market share and similar. Next slide, please. We find that, the effect size that we're seeing is similar in the margin to some other things that we might think of, not having prenatal care, a mother being uneducated and similar. Let me actually just skip this in the interest of time. Next slide, please. And so, we end up saying, well, the size of the effect seems reasonable. How many total children does this imply? And we try to do our best to this. It is a back of the envelope estimate. Next slide, please. What we end up with is something in the order of 200 to 250,000 children at peak Nestle exposure, about 1981. Remember that Nestle is about 20-ish% of market share. So next slide, please. This actually ends up being pretty close to what people were saying, in the sense that we come up with an estimate integrated over 81 to 2015 of maybe 9 million-ish, maybe 10 million-ish, depending on linear trends. Let's go to this very last slide and I'll summarize. Right. So in essence, what we're finding here. Last slide, please. There we go. So in essence, what we're finding here turns out to be about 1 million deaths per year, which is what the public health people were saying in 1980. Right. In essence, this looks like we've more or less pulled the signature out that people were talking about 50 years ago in 1975. You have this exposure to bad sanitation vector that increases mortality by a pretty significant amount. People are saying back of the envelope estimates of about 1 million kids per year in the developing world, and that's pretty similar to what we're getting, certainly within confidence intervals. Right. In terms of how we think about this, as I said, this is ongoing battle. And I think that the fight with baby formula and what to do about it is similar to a lot of other things in consumer products. How fast should a car go? What's a reasonable amount of a possible exposure to a toxin? Should you not let people smoke cigarettes? All kinds of questions where we're sort of trading off consumer goods against welfare. In this case, right, baby formula is not cigarettes. It's definitely something that has active value, and it's highly heterogeneous value depending on household income, female labor supply, other children, all kinds of stuff. So it's not like this is something that we can ban in any way. So what do we do? Generically, I think this points towards the importance of sanitation networks, the idea of generically having a tight focus on the disease environment for children. But it also, I think, to a certain extent, points out that, like, yes, these costs are there, and we have to come up with ways of dealing with them, and we should probably engage in more regulation than simply letting private firms do their thing. It's also, to a certain extent, a problem of sanitation first and foremost, and as the world develops, hopefully this entire problem goes away. So I'm going to leave it at that. Thank you for bearing with me through all those technical difficulties. And I'll open the floor to questions if it's not too late over there in Delhi.
So thank you, Professor Hughes, for your excellent presentation. And we have some time for questions. So I will request the participants to raise their hand and ask questions if you have any. Any of the participants has question? Dr. Charan, do you have any question?
Yeah, Jesse,
Yeah.
I liked your research. And I also like the fact that you brought in something new on the table, that the baby formula, just because the water and sanitation could be leading to the massive. Now, I have two questions for you. One is it not an ethical issue that knowing that this is what it can lead to, Nestle should have been more ethical? Or maybe the box or the baby food warning can be given that, look, while we have this as an alternative, but this should not be used as a supplement, or this should not be used until extremely essential, or this is a prescription based and will not be available in grocery stores. One. The other is, I know Coca-Cola was never banned, though nobody knows the formula. We all know that cigarettes, we know the formula and are harmful. They still enjoy the privileges, and there are the best of cigarettes available and expensive. And the addiction starts from the school level, which are highly subsidized. Now, the issue is that in advanced countries, has an estimate been made where I would think that sanitation is not a concern at all, or even the tap water is better than the bottled water? Would there be any estimate that the baby formulas lead to mortality even in those countries?
Okay, well, I'm going to deal with the second question first. What I'd say is you've got your finger on exactly the problem, which is the difference in baseline water quality across countries, right? And so to a certain extent, what happened with Nestle is Nestle was moving from, selling to Americans and Germans and Brits who had already gone through their water crises 100 years earlier, right? A classic thing I'll teach when I teach my undergrads about public health is about, John Snow and the water pump on Broad Street in London in 1854. But it's important to keep in mind, right, that in 1850, many more people were dying of disease in London than they were in Delhi. Right. London was a much dirtier city, had really bad sanitation problems. And so all these countries had already dealt with their public water works issues with development. And so what was happening here is Nestle, by introducing this product into contexts that were still developing, was kind of assuming that the water would be okay and not thinking about the implications. Which brings us to the first point. I think there's an obvious ethical dimension to this, right? This is infant health and child health. The extent to which there is a normative obligation here, I think, is obvious, right? And this is, I think, part of what's interesting about doing this work is that the normative obligation to not cause harm to children is very high, especially when you're producing products for children. At the same time, part of what makes formula really fascinating is that the normative, like what the policy implications are, is not necessarily clear. And so this is part of why, early on with this, we decided to bring on Professor Fernald from public health, because in addition to being an excellent public health theorist and researcher, she also knows the nutrition literature and its politics very well. Because part of the problem is if I come out and say, okay, for example, you can only get baby formula if you have a prescription, right? Then there's a whole bunch of moms who are poorer, potentially not literate, etc., who would want to be able to get access to the formula, would be able to do something like go get another job, express agency and rights. And so having the state make the decision to put barriers between formula and everyone becomes quite difficult. So on the one hand, right, like the first thing that people thought was, oh, you should put instructions on the baby formula, make sure people know that they have to boil water ahead of time. But the problem is that people routinely don't read instructions. And also one of the major problems that was pointed out in the 70s is that you'd be in a lot of countries, people, if they are literate, maybe aren't illiterate in English. And a lot of the marketing, right, is part of why we focus on the marketing. A lot of the marketing was like, ooh, look at this baby. Look at this very happy baby from the West. Very popular, very modern. You should feed the baby formula like this. And moms would respond to this. Say, oh, I want what's good for my baby. I'm going to go buy the formula. Sure. And just make it. And never even think like, oh, there's a bunch of writing on the side in English that I should understand. And so there's instrumental in this whole project is this really, what I think is, a humbling sort of set of problems related to really basic development. Like, what is it like to care about a mom and a child in their real context? What are you supposed to do? How are you supposed to develop optimal policy? On the one hand, I think it's pretty clear that introducing baby formula this way caused large numbers of deaths. The optimal response to it, optimal regulation, I think, is a lot harder than one might hope. There's an extent to which I think that would be my core from having worked on this for 10 years. I'd say that is where we know it was very bad. The best response is not necessarily clear.
Dr. Rattan, you've been into health issues about 30 years. Well, the first thing that can be done is at least get the write-up translated in local language. wherever the milk product is being sold in India, I don't know if you've done a subset estimates for India. I'm sure the figures are going to be much larger if you had done for India specifically. But I would think that if translations were done in Indian languages, the box will only be sold if it is written, if the language is in the language, the local language, and written in bold. That could probably save a huge number of our babies. Dr. Rattan, I think this is a good idea that he has given us, that people do not
Yeah.
understand. They only go by the fashion. They see a white Western baby looking healthy, so the mother wants the same child at her home. Thank you.
So actually, it is a billion-dollar industry, billions of dollars. So I know in even the big hospitals where deliveries take place, ideally only breast milk should be given, and first breast milk is the most that contains a lot of immunity for the child. But the doctors themselves in the hospital, they give first milk from the formula. So how will you educate such people? Although as per the national health programs, up to 6 months, only exclusive breastfeeding should be done and no supplement should be given. But the things are continuing, so more action is required on that front. I agree to it. So,
Professor, can I have one question? I am Mallikarjunappa from Nite University.
sure.
Professor, this estimates that you have done, it looks like it is based on the event study before the introduction of Nestle food formula and then after. Now, did you implicitly assume that once it is introduced, every mother would use this? Or did you take the subcategory, those who have used the Nestle food and those who have not used the Nestle formula? Because some sections may not have used it. Did you find out the estimate of the infant mortality for those who have used, for those who have not used? That is exclusively, let us say, somebody who is breastfeeding and not using Nestle formula at all, and those who have used Nestle.
Yeah, excellent question. So the problem here is that we do not get retrospective data on each child's feeding when we get the data about the mortality. So we can't observe behavior at time of death. What this means is that formally this estimate is the intent to treat, right? It is not treatment on the treated. Treatment on the treated, we think here would actually be much worse. And to give a kind of a good ballpark estimate, if you take a child and introduce septic water, the mortality rate is like 300 per thousand. In the sense that it is one of the fastest ways to kill a child is to give the child dirty water so they get bad diarrhea. When they're an infant, they're dead within a couple of days if you're not careful. So our estimate is less than a tenth of that, right? Our estimate is 2 per 100 as opposed to 30 or 40 per 100. And so to a certain extent, this would comport with an uptake on the order of 10 to 20%, so we're not assuming that everyone is uptaking this. This is just on average mortality, and there's a black box between, when Nestle shows up and who's actually taking the formula. So, that is, if anything, we think if we could correctly identify households based on actual uptake, we think the mortality effect would be a lot higher.
So,
Yeah.
Mr. GM, do you have
Professor,
any question?
one more. Can I have one more question?
Please.
Yeah.
Okay.
How did Nestle company take this? Did they contact you on this, and then other baby food manufacturers? I'm very sure they would have contacted you and then reacted.
Nestle contacted us. Their first email was nice. The second email was not so nice, but they are not good econometricians. So they didn't know what we were doing well, and they didn't really respond well. And that was 8 years ago. We haven't heard anything since.
Mr. GM, what? Have you asked your question? Okay, he has raised his hand, but Charan, should we close or already we are?
No, I think GM Bhatt would like to ask a question.
I am asking him to ask question, but no response.
But
Are
Mr.
you?
Bhatt, do you want to ask a question?
You are
Ray,
muted,
I could hear him.
Mr. Bhatt. You are muted.
The other question that I would have for you, Professor Jesse, looking at Nestle, there are many other companies which have come up with baby foods.
Hello,
Is it
Mr.
Mr.
Speaker.
Bhatt? Yeah, please go ahead.
Yes, thank you very much. It was very nice listening to our guest speaker on infant formula. But I want to know from our speaker that in countries like most of the South Asian countries like India, Bangladesh, Pakistan, where you have the requirement of this infant formula in most of the rural areas. No need to have it in the urban areas, but the problem is in urban areas we find that they have their own objectives. They go for this formula for different reasons. Whereas in rural areas where there is a requirement of this supplement, but they don't have the resources to go for these infant formula. So I don't know what kind of policy a country with low income or medium income should pursue in order to safeguard the health of the infants in their respective countries.
Yeah, what is optimal policy here, right? Especially for rural urban difference. I mean, I think one way of thinking about this paper is that the formula is going to happen regardless. And so it's telling public health authorities, it's telling governments why it is important to make sure sanitation is there for infant health, right? And I think this is, in context after context, the fact that there's certain parts of the disease environment that have to be dealt with pop up, right? These things evolve, right? I mean, you guys are in Delhi, I'm in San Francisco. Neither Delhi nor San Francisco had to deal with bad air pollution 50 years ago. And now both Delhi and San Francisco have to do with a very serious public health problem in the form of wildfire pollution in San Francisco and industrial pollution in Delhi that have very, very serious health effects, right? And so to a certain extent, I think, I would, and again, this is the policy on this starts getting very nuanced, but I think a lot of where I would put my energy in this is in making sure that part of the first bit of information that a mom gets, right? There's all this best practices stuff that we do in infant care all around the world, and making sure that that is done for each baby in the language of the mother in a way that she engages with is paramount, right? And so a nice example of something like this in the United States, there's been a big awareness campaign for how you have your baby sleep, right? Sudden infant death syndrome. If you let your baby sleep face down, there's a much higher probability that the baby can suffocate and die. And so when a baby is sleeping, always on its back. And this is one of these things that's now at a hospital when you have a baby. They're like, make sure you don't put the baby on its back. It's a big, it's a big part of how you do the government regulatory support for the child. And I think that's where I put most of the policy thought into this is, if you are thinking about state policy in part of India and you're thinking about these things, the principal thing is, moms want to take good care of their children. And being like, okay, here's the idea. The water has to be clean. That means this. It has to be done this way. Very, very simple, straightforward direction. And I think this is the kind of thing that you can ask the company to put instructions or whatever, but that's not enough. You need the regulatory support. You need a state agent, I think, coming in and saying, make sure that you don't do this. That would be my view.
So we don't have any more question now.
Thank you,
So
sir.
I thank Professor Hughes and hand over to Dr. Charan for final. Thanks.
There is a question coming up from Rupali Ashok Yadav.
Okay.
Do you want to, can you read it, Jesse? Do you want to react? To
Yeah.
it?
What do I think the developing countries should, how should developing countries frame health policies and controlling companies' marketing strategies? I mean, I think, per my last comment, I think that I think that the state has a burden to tell these formula companies what to do. There's the obvious mortality risk here. The state should be, like I said, engaging in direct communication with moms about best practices. Marketing practices, I do think that baby formula should be treated like a general health good, which is to say it should not be marketed. Right. This is, I think, one of the big lessons the United States has gotten. The United States is one of the only places that allows marketing in pharmaceuticals, and it has messed us up so bad. I'd say I remember what it was like before we had ads for medicine in the United States, and it's obviously people pursue what is marketed at them. So if I show a bunch of moms like, oh, look at this pretty mom with her pretty baby, blonde hair, moms are gonna say that's what they want. And so I think in terms of marketing prescription, I actually think it's really important. This is the type of domain where, national identity becomes quite important. You say, no, you're not allowed to market to the children. You can think of this as a supplement that's necessary sometimes, but you should not be allowed to take out advertisements saying that you should do this. I think I may be extreme amongst health economists for this one, but I think advertising for health goods is necessarily pretty bad. Your doctor should tell you.
Jesse, I might have missed in your econometric exercise, but I'm still not very clear that if the baby is in environment, the mortality rate obviously is going to be high because the child's development, the immunity, the digestive, the cognitive strength, the digestive system is weak. Now, how did you isolate that only because the child was on the baby formula, the mortality was taking place? How did you isolate it from the bad sanitation so that one can say that it is the Nestle food or the Nestle baby formula which is cause of mortality and not poor sanitation conditions?
The basic idea here is that this is why we're doing the two-way fixed effects and the difference in differences. Because what we're showing actually is the 19 deaths per thousand that we get as our main average effect is the change that happens within a household that has bad sanitation. So we're saying, you might have normal mortality rate for a household that has clean water, much higher mortality rate for a household that has dirty water, right? Which is true. What we're saying is that pre and post Nestle entering, in the clean households, nothing really changes, but in the dirty households, mortality goes up. So that's why when we include, for example, the fixed effects for mothers, really the fixed effects is a within estimator. So it's controlling for the average mortality of each of the different moms across all of her kids. So we're really just saying, even if a dirty household had higher mortality, a child born once Nestle has entered into the country compared to children born to the same mother in the same household 5 years earlier now has higher mortality. So we're getting that time difference that allows us to do the identification.
Then that question which was asked by Malkarjunappa is relevant, that in the same locality, if somebody was using the Nestle and not using the Nestle, was there a difference in mortality of the households, child mortality in households? Was that study
So
done or not done?
we can't observe that because so what we're doing instead, this is also why we're focusing on the marketing, because everyone gets the marketing, right? It's just the presence of the product in your local market, right? And you see the Nestle sign. And so what we're saying is the mortality effects that we're getting of 0.02, 0.02, excuse me. We're getting mortality effects of 0.02, whereas typically a sanitation mortality effect is like 0.3 or 0.4, right? It's like 300 or 400 deaths per thousand. We're getting like 20 deaths per thousand. The 20 deaths per thousand that we're getting, one has to think of as the mortality effect of 3 or 400 per thousand multiplied by whatever this market exposure uptake thing is. So what we're showing is that on average, if you look at the overall market divided into moms that are clean versus dirty water, right? If you're a mom in a dirty water household and you get exposed to the Nestle market, mortality goes up. And so we can't directly observe the intermediary processes, but we know that it's related to Nestle entrance and we can time it very well.
The last question that I would have is, there are many other companies in the baby formula now. Now, is it Nestle the only one which has some ingredient which leads to higher mortality, or this is applicable to all baby formulas?
We think it's applicable to all of them. It's basically the same stuff every time. So they just happen to have very, very good records, so we could write the paper.
And they did the mistake by writing their annual report regularly.
Yeah, very Swiss.
Exactly. All right. So, Dr. Rattan, I want to thank you for chairing the session. You are an expert in this, and I'm happy that you've been able to listen to the whole thing. I think there are some very easy lessons that we can draw from this. One of it is, of course, how to get things translated in local language of the mother so she knows the pitfalls of blindly doing it. At least boiling of water should become a precondition to using the baby formula. The other, of course, is the doctors and the nurses and the healthcare experts have to tell the mother that, look, this is the last resort. Please don't move in here. The track record is not very good. And nothing to do with Nestle or nothing to do with any other baby formula. All of them are equally lethal in terms of mortality. I think the third thing is that in India, Jesse, this may be a news for you, but for Indians, we all know it. We had a great Emperor Akbar, and I think his mother was not able to take care of the feed, and therefore a substitute mother was used to feed Akbar. Am I right, Rattan? It was Akbar or Akbar's son or Akbar's father?
I don't know
Yeah,
that history.
yeah. So there is this problem that there were substitute mothers who also had a child and were in the same stage where they were feeding their own child. They would feed the child of someone else because the biological mother was not able to take care of it. I also understand that in the Western world these days, they have milk banks uh, in hospitals and in wards where young mothers are coming in. So there are alternatives to baby formulas, and probably those need to be explored. In India, cow milk, and there's a typical breed of a cow which is considered that cow's milk is considered a perfect substitute for the human mother and the child. You yourself in your initial stages showed that the goat was serving as a surrogate source of milk. So I think there are ways that need to be explored so that the baby formulas don't have a runaway success. And I think the last one is, of course, which I said, prescription, make it prescription based. So every time the mother goes to buy the milk box or milk powder, she is once again reminded that there are pitfalls and this is not just a grocery item. I must thank you, Jesse, for sharing all this information with us, your excellent research in a developing country like ours. We need such research. I hope your next project will be doing it on India and telling us whether it applies to India and what is how many babies we have lost just because of this error that we have done. And there are quite a few of Indian scholars, your colleagues in the University of San Francisco. I'm sure somebody will team up with you. So we hope we'll have a good research on that. I want to thank the participants from 8 to 9:30 on a beautiful Friday evening. Sitting with us and talking about these issues shows how dedicated you are to research and public health. So thank you very much for it. One housekeeping announcement. Next week, we are going to have a fascinating topic, and that is inflation formulation by a central bank in periods of uncertainty. I think that's another solid econometric exercise, and that will be fun to listen. How do you formulate a monetary policy when you're not sure of anything, neither the exchange rate, nor sure what Trump will do, nor sure what Mark Carney will do, not sure what will happen in your neighborhood? So, what do you do with your monetary policy? So, that is coming up next Friday, which is 30th. On 29th, the economic survey is coming up. You will find me, Dr. Rattan, my colleague. We will be discussing about the economic survey on 29th as it is presented. On February 1, which is a Sunday, Jesse, we work here on Saturdays and Sundays. On a Sunday, our parliament will be passing the union budget. And on Sunday evening, we will have at EGROW a discussion on the union budget. So I would request you all to please be watchful of the events that are happening at EGROW. The first one on 29th, economic survey. The second one on 30th evening, discussing monetary policy formulation in uncertain times. And the third one on Sunday, looking at the union budget. So Thursday, Friday, and Sunday are crucial. If you have missed it, today morning we had an excellent discussion on base year, and none other than the secretary from the Ministry of Statistics and Program Implementation made that presentation. It is on EGROW's website for all of you to watch. With that, let me thank once again Professor Jesse, Dr. Rattan Chand, my colleague, and all of you for being with us on a Friday evening. Have a great weekend and meet you all next Thursday. Thank you.
Thanks,
Thank you
everyone.
very much, sir. Thank you.